ASAM criteria. I have to demonstrate that I meet ASAM criteria, so my clinical staff have to get really good, because otherwise, what's the county gonna say? Sorry, you don't meet ASAM criteria for that level of care, we're not approving it. Kind of a new wrinkle, okay? This goes on, talks about all the other levels that are included. This is actually from the Marin County Drug Medi-Cal ODS plan. If you don't have it, it's a great read, 75 pages of fun and frolic. You can learn all about what Marin County hopes to do with Drug Medi-Cal. This is just a little picture that was a nice summary of what it is that they hope to do, and it looks like the big circus tent I've been talking about for the last 50 minutes. ACOs and health insurance companies have to make ACO-like changes. So if you're a health insurance company in California today, here's what is new. This is actually quite new in the last 2 weeks. Law, California law, health plans will be required to dock hospitals at least 6% of their payment if they don't meet quality standards. The exchange, known as Covered California, will require health plans to identify hospitals and doctors that are performing poorly on a variety of quality metrics. The plans must dump the providers from their networks as early as 2019 if they don't mend their ways. Health plans must assign primary care doctor to every enrollee within 30 days. These are commercial health plans. Must share data to better track and treat patients with chronic conditions. There's the chronic conditions. Plans are obliged to monitor and reduce health disparities among all their patients, starting with 4 major conditions: diabetes, hypertension, asthma, and depression. You treat people with depression? Yeah? Hope so. They're also required to better manage the price of high-end pharmaceuticals and aid consumers in reducing the cost of expensive drug treatments, and help consumers better understand their disease and treatment choices and the costs associated with them. There's this other thing CMS is doing, which is called CPC Plus. CPC Plus is, are you familiar with a patient-centered medical home model? It's a hub and spoke that puts the primary care physician in the middle, and then this whole array of providers around them. And everyone goes back to their primary care physician. It's like home base, right? Kind of like kids we played, or games we played when we were kids. I always go back to my primary care home. Then I get sent out, but there's this articulated network of providers, and I could go on, and it sounds an awful lot like the circus tent, because it is. It's a circus tent that dates back to about 1965, and it was the American Pediatricians Association that invented it. Here we are, 50 years later, still implementing. There are lots and lots and lots of these patient-centered medical home models all over the state of California, and the other name they have is Health Home, which we saw in the waiver. Okay, so CPC Plus goes a little bit further. It affects some 20,000 doctors and 25 million people. For patients with complex medical and behavioral health needs, including as appropriate a systematic assessment of psychosocial needs and inventory of resources and supports to meet those needs. Sound familiar? It's all the same thing. Slightly different words, different revenue streams, but every one of those different revenue streams is an opportunity to have a different revenue stream, and wouldn't it be nice if 75% of your net didn't come from Medi-Cal, right?
Question I'm dying to ask before your ride comes is to try to put you, Patrick Gauthier, and imagine that you are a member of this board of directors. And given everything you've said so far and everything you know, you are part of the group that is going to hire a new CEO for this organization at this moment. Given all of this, what do you think are some of the most important competencies that you would want that new leader to have?
I'd want them to understand policy, because this is there are 50,000 pages of policy so far around the Affordable Care Act.
Mm-hmm.
The act itself is 2,000 pages long. Just to give you just a small dose, the plan I helped LA County write for their drug Medi-Cal ODS waivers, 175 pages long.
And our new CEO has to know all that?
No, they don't have to know all that. They have to be competent enough to read I read the Marin County plan before I showed up here.
Okay.
Who else has read that plan?
I have, but I have no life.
Right. But you see what I'm saying? So you want someone who understands that they have to read that. You can't not read it. You can't not read the waiver. The waiver is 650 pages long, the Medi-Cal 2020. But you have to read it because it's a description of the terrain, the ecosystem that you're in. 75% of your nut is hanging on the balance of that 650-page document. So you can't not read it. And in order to read it, you have to understand policy and how policy gets formed and how this is an opportunity, but that isn't. What's the pattern? That's why I have bold things on the screen. It's like, notice the pattern. It just keeps repeating and repeating and repeating. So from a strategic standpoint, it's like, I think I get it. I think I get the point. It's popping off the page now. But now I need another competency, which is I have to be able to negotiate with other providers, because that circus tent, it's not gonna be a lot of fun all the time. They're not serving pizza and ice cream all the time. There are gonna be other people, there's gonna be like a hockey game, there's gonna be some elbowing in there. And I gotta get in there and I gotta figure out very quickly who are the people and how do I figure out who are the people that I can safely do business with. Because once I enter into these agreements, it's like a little bit of a wedding, and there's some financial risk because these are global payment risk-bearing contracts. So now I'm not just billing for 75% of my nut, I'm at risk for 75% of my nut. So I have to understand the kinds of business models and business relationship types that are going to be well suited for my organization and be able to identify risk and identify opportunity. Because if I can't identify the risk, this whole thing could blow up. A year from now we're toast. Because I got in bed with the wrong partner and they pulled the trigger on something and that we couldn't see. Those are unforeseen circumstances. And if I'm blind to those, if I can't see those, I'm in trouble.
So how would a community-based board of directors who come from a variety of fields, how do they know their CEO is succeeding or failing?
Contracts.
Okay.
Good contracts. That your accounting, your legal folks look at and say, this is a contract we can live with. We have done our due diligence. Due diligence is critical, right? Because like I said, to me, the question is not should we get under a circus tent, you have to. The question is, once we get under that circus tent, who are we doing business with? Is there another circus tent? Which is better of the two? And now I gotta get into understanding, because and it happened upstairs, where people said, we ought to develop a solution for everyone under that circus tent, which is not the way that I suggest you do it. What I suggest you do is get under that circus tent and say, what do you guys need? Tell us what you need.
Do we have circus tents here?
Yeah, they're gonna, if they're not here now, they're gonna be here.
I don't know. I wouldn't know.
Other than Kaiser?
Other than, Kaiser is a circuit tent, but it's not one we can join.
Well,
You can contract with them. That's the other competency is contracting.
We do.
No, they don't. They're having big issues with their.
So that there's a joint venture partner.
but that actually leads to my question, which is, can we be under more than one circus tent?
Yes, none of them are exclusive.
And
They
could
can't
we-
be exclusive.
Okay, so we could be under more than one circus tent because that relates to certain kinds of services. could we be under more than one circus tent where we have, provide the same services?
Yes.
Okay, so all options are out there for us. It's just the other than sitting on our hands.
Yeah.
You said you read the Marin County plan. Are there things you think they missed, given what you've seen around the rest of the?
I think they underestimated the demand. They looked at historic demand, and looking at historic demand on drug Medi-Cal and the block grant is looking at 10% of the data and drawing conclusions about what your future demand on the system is going to be based on historic claims is, sorry, but that's like asinine.
So does that mean it will be underfunded?
No, they're going to get the funding they need. It's an entitlement. And that's the thing that a lot of counties, and Marin has made a big mistake. They don't understand this is an entitlement. That means every single person who shows up for treatment has to be served. They have to be treated. And they've used historic utilization to, as their sort of epidemiological data, and it's a stupid thing. It's just stupid. You don't do that. It's sort of, it's a childish mistake to me. Okay.
So, Patty, I think you're saying then if someone who's homeless shows up, I mean, there's a requirement
Yes.
for no more homelessness, basically.
Yeah, you have to do what you
Yeah.
can to house that person. Then you have to treat their substance abuse. If they show up, and what's different about ASAM is if they show up drunk, admit them, which is very different. A lot of counties, if you show up drunk, they get to say, go away and come back after you've stopped drinking for 3 days. And if you think about the nature of alcoholism, how wrong-headed that is. Or to kick somebody out because they got drunk. It's like you exhibited symptoms, you're gone. You know, so we've got that, all that changes.
And partly you're throwing a lot, it's not my background, so my little brain's trying to wrap around it. So I'm going back to the county again. If they underestimated demand and it's an entitlement, where's the money coming from?
Federal government.
It's federal.
But they're probably gonna find themselves short of providers. They're not gonna be really prepared
Got it.
for the demand.
Yeah.
They can't really.
Aren't they
That's-
kind of seeing themselves as the umbrella, as the?
Well, yeah, that was my, are they
Yeah,
the
I
pole
mean,
of
They,
the
they're-
circus?
they
they
can't
think-
be, because remember, we go back to this thing, and they have to have a managed care plan. Has to be in this.
Does the plan say who they're, that?
On ODS, no, but on, because these are different waivers. ODS waiver, they don't have to have a managed care plan in place. But for Medi-Cal 2020, which is the overarching waiver that supersedes all, each county that decides they're gonna be their own plan, some counties can couple up with other counties and create kind of a super county. They have to have a managed care plan as a partner. Then the county, then community-based organizations. Those are the three ingredients.
So does Marin say who their managed care provider is?
I haven't read their Medi-Cal 2020 plan.
Okay, you
I
read
think
it?
they're working on it.
Okay.
It's just-
Yeah, their
Yeah.
managed, their managed care plan is currently Partnership Health. So I'm not sure, you know, I've read it, but I don't remember the details of what the Medicaid, what their waiver says about that.
There are a couple things, just because I want to kind of remind us, don't just think about Medi-Cal. Think about, because this is happening in every sector of health insurance coverage. These two articles came out in the last week. Half of US cancer deaths due to bad habits. Okay? Now we kind of know that, right? Because we think all the smoking and the people
Oh,
smoke.
yeah.
Team at Harvard Medical School calculated 20 to 40% of cancer cases, half of cancer deaths could be prevented if people quit smoking, avoided drinking heavily, kept a healthy weight, and got a half-hour a day of moderate exercise. Next article, alcohol and high blood pressure, dangerous mix. This is something most people denied for a very long time. For someone with high blood pressure, drinking even in small amounts can impair functioning of the lower left chamber of the heart. 1/3 of US adults have high blood pressure. I love this kind of data because what it does, it informs me of something the hospitals read this stuff. This is what they look at and they go, how are we gonna help people who are drinking even a little bit a day? We don't have that capacity, right? So this is a pain point because now the hospitals, instead of just treating this, are gonna be paying for it. They're not gonna be getting paid for it, they're gonna be paying for it. So articles like this suddenly become very important. Could we develop a behavioral health line of business that targets high blood pressure and alcoholism and bad habits like smoking and drinking and not exercising and cancer? Or how about diabetes and obesity and concurrent mental health and addictive disorders? This is a field called behavioral medicine. 150 medical schools across the country have opened behavioral medicine schools where they're teaching, they're not just teaching a class on behavior to MDs. The MDs are getting a specialty in behavioral medicine, which is not psychiatry. It's this.
They have it in Oakland, there's a big school in
Yeah.
Oakland, there's a couple, like, even online.
And again, that's one of those things you say, is that an opportunity or a threat?
Opportunity.
And a threat.
Yeah.
Because if you don't do anything about it, pretty soon,
Yeah.
everyone's gonna be going to their primary care physician for their mental health and addiction treatment, which they already are.
Patrick, you said that organizations like Buckaloo are gonna have to get under the circus tent and find out what some of the needs are.
Mhm.
Do you know of any organizations like Buckaloo, either in the San Francisco Bay Area or where you're from in LA, that have done this, that are ahead of Buckaloo,
That are ahead
that have gotten under the circus
in
tent?
California, certainly not the Medi-Cal 2020 circus tent. This is, you're right on the cusp of the Medi-Cal conversation. On Medicare and commercial health insurance, ACO side, a couple of folks that I've worked with that have wondered, should we go talk to Kaiser, for example, and came away with contracts because Kaiser said, thank God somebody finally came and talked to us. We needed residential substance abuse treatment, for example, because we don't have it.
Organizations like Buckaloo have done
Yeah.
that.
Oh, sure,
Yeah.
sure.
Yeah.
Got a
We need to-
Kaiser
we need to
contract with
expand it.
MSW.
We have a Kaiser contract for residential care for drugs.
You know, and what you just keep pushing on, because once you have one, it's,
Yeah, the
keep
second
leaning,
thing-